in a discussion today with someone from Dentaltown who tells me how he does his splints and how he gets everybody better. And I made the point. I said, well, that's very all well and good, but the fact of the matter is that you still haven't given a diagnosis. So, if you're talking about that splint and you're talking about some sort of autonomic or sympathetic dysautonomia, or you're talking about atypical trigeminal neuralgia, or you're talking about some ligament insertion with referred pain pattern, a odontological pain pattern, if you're talking about chronic regional pain syndrome, if you're talking about effects of pain from Lyme disease, somehow your splint is not going to matter. And to suggest, therefore, that they're very upset with the fact that there's a specialty now in pain management. And he doesn't need a specialty, he does his splints a certain way. So it's those kinds of arguments, silly arguments, continue. And they really, it's a shame we all lose by that silliness. When the organizations I was involved with moved and sleep came into pain management, the organizations in general took the premise, we're the ones who should be treating sleep because we're the ones who are experts in joints. And if you're going to move that condyle, then then you should know what you're doing. And if we look carefully at this, at good evidence-based pain management, movement of the condyle happens coincidentally, is not the essence of the cause of what should never be the goal. You're not in pain or dysfunction because the condyle's not in the right place. And the proof of the pudding is John Viviano. That ugly face should tell you everything. And why do I say that? I say that because here's a guy who was doing sleep and hearing about all these TMJ complications and moving the condyle. If you take a patient and you move them 2 or 3 millimeters forward, which is usually about at least where we start, you might be shocked where you're taking that condyle and putting it all night. Usually just shy of or at the eminence. Seriously, we've taken tomos over and over again and looked at this thing and said, oh my God. And then I'm laughing and thinking, oh my God, here was Dawson and Gelb fighting over where the condyle was supposed to be. And here we are taking it out all night and putting it wherever the hell we wanted it. Not even knowing where it was going. Not that they did either, by the way. Not even knowing where it was going. And understanding you think all the corrected tomograms you want or CBCTs you want, and it still didn't matter. So not even knowing where it's going. And getting people better and not running into difficulty. And some really excellent research, Don could come up with it. Don, we just did a paper with one of the papers went into depth on how joint complications are overstated and not as common as people want them to be. So you could be all the expert you want. But what we came up with was the following, and the summary was this realization, is that by holding the jaw, the condyle out at night, or holding the jaw and the condyle coming out, remember that there is no pure translation. There is no pure rotation. So as soon as that jaw, even if you just open the patient up and you don't bring them forward, that condyle comes forward. There is no pure rotation. So and then adding, and actually the strain of holding that condyle forward isn't in the musculature. We're not asking unsupported muscle to hold that condyle forward. We are taking and holding the condyle forward, and the strain's being supported by what? By the appliance. If we take resting EMGs, which are generally useless, right? But if we take resting EMGs and we hold the condyle forward and then retake resting EMGs, we see no change. The musculature is not activated by our appliance. Now, when we bring the condyle forward, of course, what are we bringing forward? We're bringing the condyle forward, and we're also, of course, well, by bringing it forward, we are opening and the lateral pterygoid is also bringing the disc forward. So we still have the normal condyle disc fossa relationship. It's just further anterior. And the reality is that when you look at all the complaints of all the issues with joints in sleep implants, almost always, what is it? Was it I created a disc displacement with disc displacement with reduction? Did I create a disc displacement without reduction? Did I do any of that? No. What did you create? What was the complication? What's the significant complication that occurs in very few cases? What is it? Pain. It's joint pain. And once you look at the anatomy and the physiology of the joint and you understand that you haven't ripped anything, you haven't torn anything, you haven't taken any ligaments and ripped them by holding the jaw forward. No, your position is no different than if you hold the jaw. You're not putting great strain on the joint by holding it forward. If you think of the joint pain as what it is, either a sprain or a strain of the joint, usually with some increased exudate, some increased inflammatory response. And this increased exudate and inflammatory response may result in pain. It also may result, interestingly enough, in what? In the inability to close and find your bite, have your teeth come together in maximum metacarpation in the morning. It's that increased inflammatory exudate that or all the muscle engrams and etc. But so keeping a couple concepts in mind. One, that we're not creating a major joint problem. We can't by holding the jaw forward. Two, that we are taking the condyle out of its safe harbor and we are potentially in sleep. So consequently, we have that potential of elevated or muscular activity at night, and that parafunction can direct forces and lead to a sprain or strain of the joint. So looking at how that happens, this is why having balance is helpful, because it's going to keep forces somewhat well distributed between both condyle. And if in fact you have developed left pain, if in fact you have developed left pain in your joint, there's a very good chance you've got some right-sided contact that is working against us, and vice versa. So understanding now that also a major concept is that there is no direct relationship between the amount of pain we experience and the seriousness of the problem. So because the patient has a lot of pain, it's frightening to the general dentist. And what's frightening to the general dentist is, I don't know what's causing this pain, therefore I may have done something, and the Bermuda Triangle comes alive in our heads, and we're thinking, we've done something terrible. And the reality is, you haven't. You haven't. So this is why, as you know, this is why Don and I particularly like anterior midpoint stop appliances, and we've beaten that to like a dead horse. So I don't want to go further into that, but with sleep appliance. But it's not the strain or sprain in the joint is usually an inflammatory response that we can treat simply by altering the forces, by changing the occlusal scheme. That will alter the forces, whatever is contacting, whether it's anterior, just changing it, altering the forces, decreasing the forces by anteriorizing the contact, and going to anti-inflammatories, and either using anti-inflammatories at night, before bed, or if it's serious enough, using considering steroids, oral steroids. So The reason it's frightening to us is what scares us most is that which we don't understand. And it's a little frightening to that dentist who doesn't know that he's not caused a major problem, even though the pain's severe. And then the thought is, oh my God, I better stop doing these appliances because you need to be a TMJ expert. And the reality is, what John has discovered is that you really don't. It's really overstated. Now, one of the things that's happened recently is that, and so before I go into the oral facial pain, let's go a little bit further then. So what about doing an evaluation prior to determine whether or not the patient is a candidate? I can honestly say that never, ever have I done an evaluation and said, as a result of this evaluation, my patient is not a candidate for oral appliance therapy. Now, certainly, if the patient's got limited range of motion and limited protrusive ability, your concern is, am I going to be able to get to where I need to get? And there are some steps you can take in order to increase the range of motion and the protrusive ability. But I've never looked at a joint and said, this joint's clicking, I shouldn't be using an oral appliance. This joint's grinding. I'm hearing grinding sound. So therefore, I'm suspicious of what? Anybody? I'm suspicious of
DJD.
Yeah, some degenerative changes. So the thought is, well, no, you got to step away. Well, you have to step away from when you think about degenerative changes in this joint. Degenerative changes in this joint is no different than degenerative changes in any other joint. When you're dealing with degenerative changes of joints, what causes the degenerative changes to get worse is what? Who has trouble with their knees? Like I do.
It's when you have it loaded.
What?
It's when the joint's loaded.
Yeah, exactly, John. Weight bearing. Weight bearing is the problem. Are we weight bearing more with the oral appliance in place than when we are with the pure dentition? Not evidence of that. None whatsoever. In fact, if we move, as John does, and as Don does, to anterior midpoint stops, we're weight bearing less with the appliance than we are with our natural dentition. So actually, an oral appliance has the potential to be helpful in terms of degenerative joint disease. So we don't look at degenerative joint disease, therefore, and suggest, well, therefore, we can't use an appliance. We don't look at a degenerative joint disease. So how important then is the examination? And the examination is important, not because it gives me any clue about, well, I better be careful not move them forward and move them anyway more forward. I don't have any evidence that the more forward I move them, the more strain there'll be in the joint. None. No evidence, no suggestion of that. That's all science in the absence of logic in the absence of science. We don't have any evidence of that. So it's not, well, I've got to be more conservative with this patient. But so when we do a clinical examination and we palpate the lateral poles, remember, if you're going to palpate that lateral pole, you put your hand on the joints and then have your patients open. And for every 10 millimeters you open, that condyle is going to bow out a millimeter. So most patients need to open about 10, 15, 20 millimeters before you can feel that lateral pole. And then once you feel those lateral poles and you have them hold and you palpate, and remember, it's the lateral pole that's most likely to be the first ligament insertion to be compromised, and that's because the lateral pterygoid muscle has a medial tension on it, and so the lateral ligament is up higher and weaker than the medial collateral ligament. So usually the first damage that's done is to the lateral pole, and if there's a significant damage, when you palpate that, patients will feel that. And whether they may be clicking, they may not be clicking, doesn't matter. You palpate that and you say, okay, they're positive. And then you palpate the posterior superior region and you find that they're usually positive in the same joint. that's not a patient that says, boy, I'm not going to treat. That's a patient that says, okay, this patient's got something going on where there's some compromise and already some inflammatory response, already some compromise in the tethering of this condyle. This is a patient I need to be careful of because I don't want to increase the forces and take forces that are already somewhat destructive and add forces that are more destructive that would lead to a higher rate of progression of my problem. It's that simple. So I want to make sure that whatever appliance I'm doing has the potential to decrease the forces. And consequently, not only am I going to potentially help them with sleep, but I have the potential to allow that to change those destructive forces to forces that are adaptive, that are within that patient's capacity, and even possibly get some healing. So that's the reason we do an exam, not to rule out people from potential, but keep in mind to lock in our heads when I put this appliance in, I want to keep in mind where we're going. And then this is the patient that when I go and I take a bite registration, and I determine where I want to take the bite registration, no matter how you're taking it, whether it's I'm not even going to go there. So no matter how you're taking the bite registration, when you finally picked your bite registration and you've got a phonetic bite with a patient 87 millimeters open, or you've got like a normal bite, whatever it is, you now tell that patient in that relationship to move the jaw to the right, move the jaw to the right, and have that patient clench. And what I'm looking for is, does that cause any tenderness or tightness where? In the contralateral joint. Is this position, whatever it is, height, in terms of vertical, am I putting more strain on the joint that's going to irritate what's already irritated? And if I don't make that work, if I do make it worse, do I then go further forward, further back? The answer is I don't know. Do I decrease the vertical, increase the vertical? I don't know. I move until I change it until I don't cause that discomfort. And it's amazing. Every time you change it, you will find a position that doesn't cause that discomfort. It's more important to me right now not to have whatever is compromising the joint aggravated by that sleep appliance. And this is the first clue that we have. So that very much covers the joint itself. But what other areas tend to be irritated or tend to run into give us problems with sleep appliances? Interestingly enough, and this is controversial, so interestingly enough, it tends not to be muscle. I'm a firm believer that muscle, and this is, again, so this is as evidence-based as some of the other things we're talking about, that muscle tends to get overrated. I think of muscles as the pushers. Muscles are what causes the activity when they contract, but the pushers aren't the ones that get hurt. It's very rare that you palpate the body of a masseter and somebody says, that hurts me. It's very rare that you palpate the body of a deep cervical muscle and you say, that hurts me. That's rare. It's more common that you palpate the origin of the masseter, which is the inferior surface of the zygoma right underneath the canthus of the eye toward the medial, so in here. So that's more common. Or the origin or the insertion, that's less common. The most common thing, think about this, the most common area that's injured in a sleep appliance other than the joints is the stylomandibular ligament. And the reason is, ligament's purpose, as we know, is to limit motion. And what limits the motion in terms of protrusion? The stylomandibular ligament. Its origin on the styloid process and its insertion on the posterior border of the mandible, about a centimeter up from the angle on the medial of the ascending ramus, posterior ramus. So palpating that and learning to palpate the stylomandibular ligament, because that's like when you try to palpate the lateral pterygoid, even though you can't palpate it, you can make anybody's lateral pterygoid hurt. You can make anybody's stylomandibular ligament hurt. So learning to put just a few pounds of pressure to attempt to pick up those patients who are positive, and when these patients are positive, that suggests to me that this is a patient I'm going to be a little bit more, now for the first time, I'm going to be a little bit more conservative in my initial bite registration, because yes, this is the ligament that limits protrusion, and I'm not going to. If I have an option, I'm going to take a John Viviano bite. I'm going to ask, are you comfortable there, and be a little bit more conservative when I start. All right. This makes more sense. I'm more concerned about the bite registration being appropriate for any compromise in ligament insertions or joints than I am in terms of where it's going to be efficient or effective, because we don't have an answer to that unless we've done some study that involved that patient while they were asleep, whether it was a DICE procedure or whether it was a matrix. And if we haven't done that, then we don't know. Well, then we have no clue about where it's supposed to be. I don't know. And imaging doesn't give us anything. Variometry doesn't give us anything. This gives us I'm not thinking in terms of picking a position solely based on effectiveness as much as I am in one that I feel that my patient can start with, be comfortable, and then we can slowly progress, especially if we've picked up compromise in the examination. This is a lot different than what I hear. So in general, what's often taught is that, one, that you're going to cause serious joint problems, and two, that there's no direct relationship between the exam. I've seen so many people say, I've got to do a comprehensive exam, I've got to touch everything and palpate everything, and I've got to do this full muscle exam. And to be honest with you, the vast majority of people who do a full muscular exam when it comes to pain management do not use that examination, or use it incorrectly. Oh, the patient's got anterior temporal headaches and they're positive to when I palpate the anterior temporal, so that muscle's sore, that's what's causing the headache. Trust me, that's not the case. That sore muscle isn't causing a headache. So there's a lot of hooey that's associated with the need to do this clinical exam, and it reminds me a lot of it's like suggesting, oh, I need to do this clinical exam to determine whether or not my patient's got sleep apnea. And we hear a lot about that, well, if they've got scalloping, or if they've got wear facets. That wear facets are caused by the bruxing, which is caused by sleep apnea, which we have discussed in the past, how outlandish that, there's an potential association, but not a direct cause and effect. And so there's lots said to kind of connect dots to make us all understand mechanisms and feel good about that. And the reality is that all the dots are not as connected as we'd like. And looking at this more practically and more realistically is what John Viviano did, essentially, kind of based on his own instincts, instinctually. And people get bogged down in this confusion. The American Association of Orofacial Pain just passed and got approved as a specialty, as a sponsor for the specialty for orofacial pain. There's a lot of politics, and I don't want to get into it, and Dennis knows them better than I. Dennis also knows that a long time ago, I've fought the AACP. It's one of the reasons many of the people in AACP don't find Dr. Barry very friendly, are not appreciative of him, because a long time ago I went in front of the board and argued that this specialty, this fight over the specialty, is making no sense. I had no problem with the specialty. I had a problem with a fight over who was going to sponsor it. And there's still legal suits going on, and it's crazy. I don't want to go into it. What I will go into, the reason I brought it up here, was that when the AAOP got their specialty, they included in it sleep medicine. And this has a lot of people really unnerved, because the thought is, so are they the specialists now in sleep medicine because they are because those who are um, boarded by the American Board of Orofacial Pain have sleep medicine in it? And the answer is absolutely not. That has nothing to do, that has no effect. There is no attempt there. There is no claim that they're the ones that have any more training or are more specialized. They just wanted to include it because in the interest of medicine, John, what they're looking for is to improve the relationship of dentistry to sleep, get improved coding, improve what, frankly, the American Academy of Dental Sleep Medicine has done so poorly over the years in developing a good relationship with medicine. I don't know that that's possible right now because it's sort of like hoping that eventually the Republicans and the Democrats are going to come together and beginning to intelligently talk to each other and compromise with each other. Yeah, that's going to happen any time in my lifetime. Not. But it was an attempt, but it's of no concern to me. I'd also like to tell you that anyone at this point who would like to become a specialist in pain with the American Board of Orofacial Pain, anyone for the next year and a half to 2 years can go ahead and take those boards. You don't have to be a member of the AAOP. You can go and take the boards for pain management and become a diplomat of the American Board of Orofacial Pain. And then a year later, you can take your oral exam, and you can be grandfathered into the specialty of pain through the AAOP. In time, it will be exactly as it should be, and that is the specialty will be awarded to those who have taken a full 2-year craniofacial pain program as a specialist, just like you do in endodontics, just like you do in perio, etc. But it's really important that we understand that that doesn't keep any general dentist from doing endodontics, just like it won't keep any general dentist from doing pain management. And it will not, in any way, shape, or form, keep anyone from doing sleep or limiting their practice to sleep and pain if that's what they want to do. It's just important that so many of the myths about the direct relationship between and the fear, the number one reason people tend to fail in sleep medicine, in pain management, or don't get started is that fear of failure, that fear that so I've done something and I don't know what I did and it's horrible and I can't do this again until I know more. Until I know more about pain, the relationship of pain to sleep appliance. And trust me, it doesn't. It's not extensive. You don't. You don't need to be able to correct or deal with a patient with a disc displacement reduction. For example, I think it would be helpful to have a basic knowledge of why those don't always need to be treated, so that if a patient says to you, you know, I'm clicking, doctor, should I therefore not have a sleep appliance? Will this make my click worse? Right? So you've got a patient who's clicking, and it's consistent. Every time I open it, about 18, 19 millimeters, you hear it reduce, so it's kind of late. It's kind of a late click. They're 60 years old. They're 55 years old. They have the generalized arthritic condition. They're moderate to severe sleep apnea, and they're CPAP non-compliant. Anybody want to ask me anything more about their exam before we come up with the answer to, should I be concerned about that click? How to answer them? Any other questions about the click or its history? Okay, so I would ask some questions. What questions would I ask? I would ask, how long has it been clicking? Has the clicking changed over time? And the answer is, well, it's been clicking on and off for about 15 years. Sometimes it clicks consistently, sometimes it doesn't. There, it just clicked. So I just opened 4 times, it didn't click 3, and then the 4th one it clicked. Any pain associated with the click? No, never pain, but I, don't want to get it worse, right? So tell me, doctor, can I have a sleep appliance? Will my sleep appliance make my click worse? Who wants to take a stab?
I will.
Who's that?
It'd be John here.
Oh,
Of course.
wait, before you do, John.
Yeah.
Anybody else? No offense, but I know you got it. All right. Let's go with Dennis. John, hold your answer because we're going to get it. I know you won't change it.
Sometimes you just don't know. Sometimes you may make the click worse. Sometimes you may make the click better. But you have to ask the patient, what is their main concern with their clicking joint? Can they eat? Is it more of a social embarrassment? Is it what kind of functional issues are you having with this click? Because like you said earlier, Barry, you don't treat every click. But it's good to know.
So here's the answer, Dan. That's great. That's absolutely right. Great. It's great. Obviously, great. Now here's the question. I don't have any problems, Dr. Marangos. I don't have any problems. The question is, will I have any problems? Will this be a problem for me if this click gets worse? Okay. In other words, I'm looking for risk benefits here as a patient. I haven't thought. I mean, I'm not in the SACIT as a patient, but I'm there. Okay. So I'm looking for risk benefits, and I'm saying to you, if I wear this appliance, will this create more of a problem? If this click gets worse, is that a problem? Will that be a problem for me?
Well, what's a worse click? Tell me what a worse click is, because a click is a click is a click. Now, if you go to a lock,
I'm a patient. I don't know.
Yeah. Well, tell me what is your fear?
I know people that I don't want to have pain. I want to be able to eat.
Do you have pain now?
No.
There's no reason to expect that this could make it worse. However, there's always a risk, and it's risk management, 100% risk management, as you said. And you can't say that 100% I'm going to make you better, or 100% it's going to get worse. It could get you better. There could be days where you go up and down, just like you said. This patient had clicking off and on for 15 years. Some days it was worse, some days it was better. We don't know. But the one thing we do know is you can't guarantee 100% of anything. They're 60 years old or 55, whatever you said.
I got 5 years younger, and I'm trying every day to get 5 years younger. It's not working.
Look, today's my birthday, so there you go.
Hey,
there you go.
Happy birthday.
So you just don't know, right? You can't say anything. You have to be honest to the patient. And one of the things I've learned with you, because I've been with you for a million years, is you just tell them. It could work. It could get you better. It may not. We don't know. But we know that your sleep apnea, if we manage it appropriately, could get better. And you have to, it's a compliance problem issue. Are you going to wear your appliance? You couldn't wear your CPAP. We hope that if you wear your appliance, that we can stabilize your joint so that you're no worse off than you are now.
Great. Okay, Laurie, you were going to make a suggestion. Were you going to talk? I thought I saw your hand up. No. No. Okay. All right, John. I'll let you talk. John.
Yeah, I got you. Well, I have done craniofacial pain for about 30 years, which doesn't mean much of anything other than I've made some mistakes along the way, and hopefully learn from them. But so I come from a background of having done long, lengthy head and neck exams on multiple pieces of paper and multiple pages of computers, and then I got to Barry, and he's doing this 3-minute craniofacial exam before he does the sleep appliance, which I understand the value of that. And here's a confession, I don't even do that. So I take range of motion. I look at path of opening. If they have a normal range, for me, if they have a normal range and a reasonable path of opening, I don't have much of a discussion about anything else, because I know most anything I'm going to put in their mouth is going to help them in that regard. If they have internal derangement, I ask the questions Barry did. have you been locked? Have you how long's it clicked and that sort of thing? And there's not much they could answer that would keep me from putting an appliance in, unless maybe they have an AHI of 5.5. Then I may not. But then when you get to the point where you're using an anterior discluder, then all that becomes kind of a moot point anyway. And so about the only consideration I make there is maybe I don't want to have a starting point for that patient quite as far forward, which again brings me back to a tap, because it's so easy to advance that plate if you need to. You don't have to say anything back to lab. You can be very conservative on your bite registration, get an appliance in that doesn't flare anything up. And if you don't have enough titration out of that appliance in order to treat the sleep apnea, then you can always move that plate in about 15, 20 minutes. So that's kind of my thoughts anyway. So
let me do a couple things. One, the one thing I would add, everybody's right on. The one thing I would add is that at the end of the discussion, I would turn to my patient and say, Dennis, of course, there's a strong possibility, there's the possibility of an alteration of the quality of this joint noise that's been with you for 15 years that comes on and off. The likelihood of making this worse, frankly, is minimal, but possible. But I can tell you this. If you were my brother and I liked you, I would make this appliance. Together, we will monitor this, and any untoward effect, we will do everything we can to minimize. But as far as their quality of life, the potential, it's a no-brainer. So, and there's nothing I just said that wasn't obviously 100% true. Let me ask you this question. Open, close, no click. Open, close, no click. Open, close, no click. Click. What just happened? Why does that happen? Why does that happen on many patients? Click, click, loud, click, click, no click, no click, no click, soft click, loud click, no click. What's going on?
Just recaptured disk. Can anybody hear me?
Yes.
Oh, okay. Howard Hoffman here. Finally got it figured out. Okay. I think perhaps you're to recapture the
you don't
disk.
live in Staten Island. You live in Fort Lauderdale. What good am I?
It's mandatory to move here when you hit a certain age.
I'm moving in 6 months. Go.
No, I've been down in South Florida for over 40 some odd years. Okay, so I had my own disk recaptured by an advancement device many years ago. And I've never had but one person who gave up with TMJ discomfort in treating for 23 years.
Let's talk about the physiology of what's happening when that patient goes open, close, open, close, open, close, no click, no click, no click, click. Keep it simple. Just that simple.
One thing that you haven't answered here is when they open and don't click, is the range of motion normal?
It's exactly the same.
Then the disc is it's in place. It just doesn't click all the time. It just doesn't dislocate all the time. I can't answer why. But
yeah, okay. So let's talk about that. Because this disc, can you see my hand? This disc is tethered, and for this disc to be quote unquote in less than ideal relationship, this tethering has to be compromised. Whether it's the medial pole or the lateral pole, the tethering is compromised. and now the disc is not as finely held in place. And then we start to get what we learned in JVA, right, was a wobbling disc, wobbling because, and then if it gets further out, and that gets that posterior rim gets to the point where it's going to make a noise as it comes back over, fine. But this disc is not. Remember it's fibrocartilage. It's not an ideal perfect disc. It adapts and changes over time. So, and now it's wobble. Now it's not as well held. So now it can go and find a section of that disc that's not as bulbous in one point, and then recapture it quietly. And now the next time it's in a little different position, and it picks up that part of the disc that's not so ideal, and it's a little more bulbous, and clicks over. Many times what will happen is all of a sudden the patient will say, yeah, I clicked for 15 years or 10 years, and now I stopped. And oftentimes the assumption is, well, now it's displaced and it's not recovering. But the reality is what? No, that's not what happened. What happened was, for whatever, remember this disc is fibrocartilage. Fibrocartilage is not avascular, aneural, and acts like bone. So what does bone do when there's significant pressure on it? All the orthodontic guys. It resorbs.
It remodels.
Yeah. Remodels, resorbs. And now, if that same, if nothing happened in the position, it's no longer clicking coming up. It's remodeled. It adapted. So forces that were destructive no longer continue to destroy the ligaments, attachments, and now began to allow this adaptation. And now we've got, instead of destructive forces, adaptive forces, and we're better. And we're not clicking. And just through the remodeling. So one of the goals, that's why I've said to my patient, there's a chance that this, and Dennis said this, and John said, there's a chance of wearing this appliance that this could improve this. And that's why I'm a fan of anterior midpoint stops, because I think I'm going to decrease those forces, take the forces that were destructive, lower them into the adaptive range, and potentially, rather than get continued compromise of the disc, ligament insertions, now no longer that, and now allow for adaptation. If that disc is continuing to progress into a more anterior posture, we can get some adaptation of the disc. And there are many people that do that and say, look what I did. I recaptured the disc. Well, the reality is recapturing isn't as common through these kinds of procedures as not. Howard's right. Many times we were trained to recapture by bringing the condyle underneath the disc, by bringing the jaw forward. And we never considered about all of the adaptation we were asking the rest of the body to take in terms of cervical response and the cervical vascular system by doing that. We were isolated only on the joints, and this wasn't ideal. And now I could create an ideal situation by bringing the jaw forward and then asking the rest of the body to do that, to adapt to that altered position. And assuming we were taught that this makes everything better and everything's going to line up, and now the testicles were going to lie evenly, because after all, now we've balanced the body. We've balanced it. This is where it wanted to be. No, it's not where it wanted to be. That's not where I wanted to be. The disc went out of place. So it's not as though the condyle, the jaw, and all the jaw structures, and now we got to remove all the teeth. That's where it wanted to be. That's crazy. That's that in retrospect, when you look back at the concept. Don't get me wrong, Dennis. No, I taught that concept. I mean, I did that. And now I look at it and say, oh my God, I'm so sorry, people. No, it makes no sense. if you've got a disc out of place, or your in your knee, your meniscus is out of place, no one would take the head of the femur and move it. You'd wind up limping. I mean, and then ask the body to readapt on how it walks. No. So it's amazing that we got away with it as much as we got away with it. But the good news here is that, seriously, if everyone who did sleep knew no more about joint structure or in terms of ligament insertions, examination of the joint or ligament insertions, the stylomandibular ligament, or the origin of the masseter, if you just tested that and then adapted, made sure so you're looking to see whether your patient's compromised, and then make sure you didn't make that appliance make the forces on those compromised structures worse with your appliance. If we just knew that much, we're so far ahead of the game, and that's certainly not being a TMJ expert or knowing how the best ways to treat, joints and degenerative joint disease, etc. It's certainly not, but it's more than enough. Yeah. Okay. How we do, John? All right. Questions, anybody? Cool. You're muted, John.
Did you find those slides that you wanted to share with us?
Well, I mean, I can.
Or did you cover it off, you think?
If there were any questions, if somebody wanted to see the joints and what we're talking about, I could show them. Somebody wanted to see the muscle attachments, I could show them.
You saw the question on the tensine, right? Somebody asked, I think it was H.
That's me, Howard.
Howard, yeah, I want to see an initial here. Don't even see your video, Howard. If you want to turn your video on, then, as long as
I don't have a camera on this. I don't have a camera on this old computer.
Cool, there's no problem. Okay, so anyway, so H put that question up there about the tensine and how many people are using tensine before taking a bite registration. Did you want to talk about that?
I don't do it.
Oh, but you asked the question though, right?
Right. I was wondering if you check it with TENS especially once you get your bite, the day of delivery. If you take a TENS and get a baseline and then put the appliance in and then see where you're at, see what type of changes may have occurred.
Now you don't do that, you said.
I don't do it.
Okay.
But I might see some value with it.
Barry?
What value?
What value?
I think I'll know whether or not I'm doing anything to improve or not the muscle EMG levels.
Well, so the goal first of all, there is no relationship, Howard, between any resting EMG levels and pain. Period. So there's no relationship. And the goal of the appliance isn't to, can't in any way, shape, or form be measured with any awake parameter. So looking at an X-ray, an image to look and see if I improve the airway, looking at a pharyngometer, I say that putting my life at risk. Looking at a pharyngometer is not useful. Feeling muscle tension is not. There's no awake parameter that can tell us if we were reaching our goal. Remember, what our goal is to increase the pharyngeal dilator activity during REM, essentially. Now, throughout sleep, but especially during REM. So, we can't do. So, looking at any muscle activity, looking at any it's just like understanding that there is so much that we're taught doesn't make any sense. There is no relationship between an Epworth, for example, and the likelihood to have sleep apnea. None. Never been shown. Epworth was actually invented or discovered or originated in an Australian hospital in Melbourne to identify narcolepsy. So and then it became useful because some of our patients are sleepy, but there's no relationship between the presence of an elevated Epworth and the likelihood of having sleep apnea. None. I mean, it's not even a matter of outliers. None. There's none. So there is no relation. So we can't look at awake parameters. None. And look at it. That's why we even question the looking at a clinical exam. People say, well, look at the retronath. I had a physician that would only refer patients. Remember this, Don? Joe would only refer patients and if they were retronathic. They'd only refer patients if they were retronathic. And because that meant, oh, the jaw is back. Or the concept, remember this one, the concept that if you had a deep bite, the condyles were up and back and shoving against the retrodiscal tissue, which is just not true. There are lots of patients with deep bite who have concentric condyles. So there's lots of stuff we get taught. So we've got to understand what our goals are. And when it comes to sleep apnea, our goals are quite simple. We're trying to avert a compliance of the airway while asleep. And it's that simple. And so the musculature and the activity of the muscles at night is a total different neurophysiology than the activity of the muscles in an awake patient. And we have to accept that. We can't. And so much of that was created by dentistry because we wanted objective information. I taught for bioresearch for years, and they taught me if it's not measured, it's not science. Well, I'm a 73-year-old male, and I can only tell you, as a relatively older Jewish male, there are certain things in my body I don't want measured. Just saying. And it has nothing to do. That measurement has nothing to do with my prowess. Just say it. So what you measure there has to be science and reason to it, not logic. It made perfect sense to me that we're going to measure the EMGs of muscles, and if this muscle was sore, we're going to see, and we're going to say, oh, it's high, so I'm now going to use 10s and I'm going to knock it down. Well, the science does not support that. It just doesn't support it. So, and yet there are people who do that, and then they get patients better. And what do we call that? That's called confirmation bias. Now they're sure they understand why they got them better, and believe in that mechanism. And they'll fight with me all day long. You don't know my patients. You haven't seen me. I get everybody better. Well, you're better than I am, and you're better than all of us because none of us get everybody better. But you do so with your own philosophy of why and how it's happening. Go for it. Whatever. But we're better than that. We need to be better than that. So we can't make stuff up. We know this. If we take a two-dimensional film of a patient's airway and we move the jaw forward, guess what happens in the airway in an AP direction? It gets wider. And looking at a two-dimensional film, we say, I moved the jaw forward. Therefore, this patient's going to do well. Because look what happened to the airway. But what we know is that wide airways will often collapse. And narrow airways may stay patent. Because we've left out one of the most important things that we can't measure. And that is the neurophysiology of sleep, of muscular activity. So we need to get away from that logic. And people will tell me, oftentimes, and they'll do this with the pharyngometer, and they'll do this with CBCT. They'll say, "Well, okay, Barry, I know that it's not really valid. I know that. I accept that it's not really valid, but it's a visual for the patient. It gives the patient confidence. And I say, that's fraud. It's giving the patient something unreal that they believe in you, that you're saying it, telling them, and it makes a difference. That's not good science. I'm sorry, I don't see anything but fraudulent there. And so it's used as a marketing tool. I'd rather have the marketing tool saying to a patient, is this going to get me better, Dr. Barry? I don't know. But I know this. If you were my brother and I liked you, this is how I would treat you. This is the way I would start. And together we're going to do our best to maximize this appliance. So much better. It's just so real. And Don, you don't know this. This morning at 6 o'clock in the morning, I got on a webinar with Mike Gall from Scotland. And Mike Gall is an expert in treating dental anxiety, phobias, and fears. And he's a hypnosis expert, but he didn't talk about hypnosis. His whole hour lecture, webinar, was essentially on communication, on language. What we say, why we never say to a patient, this isn't going to hurt at all. Now, we all understand that, but that's the kind of thing. And how to explain to a patient about their fears and what to expect. And I couldn't help but think to myself, what a fabulous lesson, a fabulous lesson. There's so many things that we would be so much better off if we were better at communicating. Some of us are old enough to have gray hair, and when we went to dental school, we never learned anything about closing a case. I never heard anything about selling a case. The whole concept is so foreign to me. As opposed to, nobody wants to be sold. People want the truth, and the truth will set you free. The truth allows you to walk in to an appliance, to a patient who's worn an appliance after 3 weeks, and not have your fingers crossed and your toenails crossed and saying, you're better now, right? You're sleeping better, right? No. Why would you know? Why would you take responsibility for what you can't control? So if you go after 2 weeks or 3 weeks and say to the patient, so we gave you this appliance 3 weeks ago. Let me ask you this. On the nights you couldn't wear it, what caused that? The patient looks at you, most of them will look at you and say, what? Oh, are you kidding me? I wear it every night. Oh my God, that's fat. No, some will say, oh, well, it's tight here. It's great. That's the information. I've opened the door for communication. I haven't said do better. I worked with Harold Gell for 7 years. I watched intimidation. I watched him walk in and say, you're wearing your appliance every night, right? Yeah. And your headaches are better? And they go, oh, yeah. I said, great. And he put a notch in his belt and he walked back out with a 6'4" frame sitting over him. And I was left with the patient. And I would say, okay, so talk to him. And then I find out, well, I couldn't wear it all the time. And they couldn't eat with it the way they were supposed to. And the headaches really are a little better than they think. And then, when we do the headache analysis, we find out, so instead of getting 5 headaches a week, now they're getting 4, maybe 5. And it wasn't quite exactly as Harold agended them to protect himself. It's so great when you can be honest and not protect yourself. That improves your likelihood of success. So when you wear the appliance, do you have is there anywhere in your face or your teeth, is there anything when you wake up in the morning where it's uncomfortable or sore? No. Well, that's great. Well, it's a little sore here. Great. But if you won't get that information if you tell the patient, I don't want to hear it. I want to hear how good you're doing, how well you're doing. I want to know that after all, this is my appliance and you paid for it. So I need you to tell me that it's doing well. And that's That's dentistry moving into pain management. That's dentistry moving into sleep, where we're expected to be successful. We're expected to be pain-free. We're expected for it to work. We sold them this appliance. They paid for it. We need to make it work. We're protecting ourselves. If you set up your patient expectations with appropriate communication, what about side effects? Since this was supposed to be on side effects, how do you handle the potential for side effects? We say it very simply, and we say the following. I'm going to give you the supply. And you're going to, when we give it to you, like any appliance or medication, it has some potential untoward or untoward or less than favorable side effects. In this sleep arena, with these appliances, they include some soreness in the joint that usually is not painful and easy to resolve. They can cause some facial discomfort. That again is also usually not painful and easy to resolve, usually. And some bite changes, which usually don't affect the way you chew or the way you look, but obviously our goal is to minimize all of these. So it's really important that you tell me exactly what's happening and that you maintain your appointment. And we're done. And we're done. Now, here's the next question. The patient comes in after 3 weeks or after 6 weeks. And here's the question, right? How do you deal, what do you do to check your patient's bites? We know that we can have some occlusal changes. With sleep appliances, we tend to develop in some cases, and they're less and less. The appliances are better and better, but the less and less, we do have the potential for what? For posterior open bite. So my question is, I've already said to the patient, we want to check that they might have some minor bite change. And without putting anybody on the spot, I will tell you, this is how I check my bite. John, sit up for me so I can see your face. John Viviano, sit up. Higher, that's it. All right, John, open for me. Open, close. Bite your back teeth together. Great, thanks. All right, I have just checked John's bite. I can do this with telemedicine, teledentistry. The last thing I want to do is what? Take articulating paper and put it in his, and start looking at each dot in the guy's mouth. Why do I not want to do that? The last thing I want to do is make patients conscious of their bite. And we can drive people nuts. And so oftentimes we make the mistake by telling somebody, giving them an AM or a PM aligner, and say, or an AM aligner, and say, now every morning I want you to bite into this, and you need to get your bite back. Think about the message you're sending to them. Well, the question I would ask is, what if you don't get it back? What if it doesn't come back? How much should I force that jaw back in the morning?
I have something to interject and actually take a poll of the people that are on here right now, because I mean I have equal concerns to you about making them overly concerned about regaining their bite and then turning them into an occlusal, what's that term?
Dysesthesia.
Right.
Occlusal dysesthesia.
Right. So I have an equal concern. However, I mean, I do make AM aligners, and I just caution them on their use, make sure they're not injuring themselves when they're using it, and say, look, in spite of using this, you might experience bite change. So that out is given right up front, because I know that, well, it may be because it's just going to happen anyway, or maybe because they are actually not using it every day the way they're supposed to, that it's not always going to stop the bite from changing, whatever. The thing I want to throw out there is we have a very high-end CE provider. I won't mention a name because you'll all know who it is once I tell you what he's saying, basically because he puts out there that, and he has a big following, he puts out there that we teach people how to use these, aligners in the morning and to check not only with articulation paper, but with shim stock, to make sure, you got those tight contacts everywhere, and you obsessively document that before you even give them the appliance, and then make sure that to that degree, tooth by tooth, that nothing is changing going forward. Not only is the patient becoming, whatever that term is, the clinician is also, right? So
Well,
I mean,
the clinician was first. The clinician
right,
gave it to
he set the stage, exactly. So the point, the reason why I'm bringing this up is that you said one thing, and I know what you say. You know, we're up there at the front together saying this message. So, but there's other people out there saying completely the opposite, right? That are teaching. So I'm curious about two things. First of all, any feedback from the group here on these two approaches, and does anybody take one approach versus the other, and their thoughts basically? Because I think that, yes, Dennis?
Okay, I'll start, John. I tell my patients, your bite will change. How much and when? I don't know. Will it affect how you chew? Maybe. I don't know. But handling your sleep issues trumps any changes in your bite.
We try not to use that word in America.
Okay. Any changes in your bite? It Trudeau's that's the Canadian version, but we're okay.
Although I think Trudeau's faring pretty well in this compendium.
Doing very well.
That's another story. Yes.
Yeah, so patients' bites will change. I know, and you know what, Barry, going back to your point, I show patients how my bite has changed with my sleep appliance. And when I say, look at me, do I look like I've missed any meals? The answer is no. But my bite has changed. And you know what? It is what it is. And when you set the table that way, the number of patients that come back complaining about their changes in their bite is almost zero, because you've just told them that it could and it might, but you don't know when and how much. And do I make an AM aligner? Yeah, I do. Do they wear it? Maybe for the first 2 weeks, month, and then most patients aren't wearing it after that because they don't find it to be a problem.
So let me just let me just throw something in there. This same CE provider actually openly says to the world that, you know, with these protocols, we do not see bite changes in our office patients anymore. That's basically what he's putting out there.
Bite changes in sleep appliances are a fact. Like, I mean, it's going to happen. We know that.
You're preaching to the choir. I'm just saying that, you know, this is what's being taught, and I'm just wondering what the group here, what their experience on this is.
I have a comment on that.
That's like Dawson teaching that when you equilibrate, all of your head, neck, and shoulder pain goes away. And then when it doesn't go away, you, as a practitioner, your tendency is to think, God, if only I was Dawson, because he could do this so much better than I could, and I should go there. So that's not only wrong, I find that offensive, and I don't know who you're talking about, but
I'm not going to say a name. You all know the name. It's a very prominent name, but anyway.
Yeah, and I find it offensive. I'm offended by that, and it's not fair to the people he's teaching. John, who's it? John?
I actually do know who you're talking about, but it's irrelevant. But kind of back to what I take from Barry here, and to answer your question here, John. You know, I have an EMG, a TEC scan, serenograph, all that kind of stuff, and I found that before I was doing sleep, I began to use that equipment less and less and less. Sort of an evolution on my own. Nobody told me not to use it more or less. I just didn't need it as much to achieve the same results, and probably better results. So when I moved into sleep, it never crossed my mind that I needed all those kinds of examinations to deal with sleep. And I've not found that I ever had to go back and need it. And it's actually become more and more simplified for me as we've gone along, because sleep appliances seem to solve a lot of those issues that we worry about. Now, in more direct answer to your question here, I've reached a stage where I found, communication-wise and everything, for the most part, less is more. The more you alarm the patient seems like the more problems you have. And just because you told them about it doesn't mean you're not going to get in trouble over it. I just find that if you're honest with them, just an honest conversation, that it's not much of a problem. Do I make an AM aligner? Yeah. Do I quiz them about it every time when they're in? Not so much. Do I check the bite? Hardly ever. Much like Barry. I mean, I really don't look at it very much, and it's never been a problem. So,
Laurie?
Okay, so let me follow up on that, John.
Well, no, wait, Laurie's got something, John.
But this pertaining to what John just said, it's important. It's important. I hear what you're saying, and I understand, and I know that Barry talks along those lines. I gather it's different depending on the jurisdiction you're in. I can tell you what the AADSM recommends is that you do check all those things, and you explain to the patient what you see, and that you document it in your chart to avoid litigation or problems with your college. Right? I can tell you in my province, in Ontario here in Canada, that they would expect me to do all those things, and if I didn't, and if the patient did ever complain, and my charts went, then they would hold it against me. So I absolutely buy into the not alarming the patient, but I think it's important to evaluate those things and document them so there's an audit trail there. Because I myself have had a patient, after 10 years of wearing an appliance, she put some weight on, she decided the appliance wasn't doing the job anymore, she wanted to go back to CPAP. She was one of those that could actually tolerate wearing both. And by the way, now that I'm no longer wearing the appliance, I don't like the way my teeth have changed, I want you to pay for my ortho. And I went to photocopy her original consent form, gave a copy to her, explained that I couldn't do that. Anyway, a few weeks later, I got a letter from her son's firm. He's a lawyer, and they just wanted $50,000. That's all. So I, of course, had no choice at that point but to photocopy everything and send it off to my liability program. And a couple months went by, and I saw some email exchanges. They were looking to settle. And so I called the name at the bottom of the email that was copied, and I said, "What's going on?" And he goes, "Well, we called the college," which meant, in Ontario here, that means they walked down the hall into another room, and we asked somebody there, if what should have done. He said, "Well, the moment, this is what my liability program was told. The moment you saw tooth movement, you should have taken the appliance away from the patient, told them to go back on CPAP." And so they felt I was liable. And I said, "Really? That's what the college told you?" He said, "Yeah." "So why don't you ask somebody that knows what they're talking about?" And he goes, "Who?" He says, "Well, you could ask me." He said, "I can't ask you." I said, "You're fine." So I gave him Les Primer, I gave him Jeff Panzer, Alan Lowe, I gave him, I didn't mention Barry Glassman because he doesn't fucking know what he's talking about. But I mentioned a bunch of names. And they then, it went its due process, even in front of a judge, in order to get his opinion, and then it all went away because they couldn't find another expert to support their position. I had done nothing wrong. All along during the time that she was wearing the appliance for those 10 years, discussion about the bite changes was documented in my chart the way I was trained to do. Now, if it was not in there, they saw that it was in there, and the person that actually reviewed my chart, the assessor that reviewed my chart, could see that it was documented, explained to the patient, that was a consent form up front. They really had no leg to stand on. There was no holes. But if the stuff is missing, right, then in this litigious world, it could be. I'm not saying it would be, but it could be a problem. So I'm agreeing with not alarming the patient. I'm agreeing about not alarming the patient, but I really think it's important to document. I think.
I agree with
under no circumstances that I said don't. So there isn't on every patient, on every note, we'll note patient wear the appliance comfortably, no pain or dysfunction, no dental changes noted. Bingo. If we see some posterior open bite opening up, we'll say patient wearing the appliance comfortably, no snoring, report sleeping better, no early change of posterior open bite discussed with the patient, and that's in our note. But the discussion with the patient goes, so you remember I told you about those little bite changes we saw we're starting to see, Andy. I'm assuming, let me ask you this, Have you any change in terms of your ability to function in terms of eating or speaking? No, I didn't even know. Don't worry about it. But here's the other thing, and here's the truth. Most of my patients are not they weren't my dental patients. So they all had what? A general dentist. So I knew what was going to happen. Those patients were going to go to the general dentist. The dentist was going to say close, and the dentist was going to have a heart attack and tell the patient all the damage that's being done to the bite and that they need ortho. I know that's coming. I know it's coming. So I warned I say, now listen, when you go and see Dr. Test, right? He's going to look and he's going to have you bring your teeth together. When they don't come together exactly like he did, he's going to be very upset. Okay? We're going to send a note out to him, but it doesn't matter. He's going to be up. Here's the thing. Don't be upset with him. Don't be angry with him. It's the variation in training from a general dentist to understanding this, what's going on with sleep. It's okay. If he still gets upset and tells you got to stop wearing the appliance or you have to go to ortho, smile, just get out of the chair, give him a hug, and tell him it's going to be okay. And I'm not kidding. That's exactly what I tell them. So they are totally prepared. They have to be prepared for the next dentist that sees them that's not trained. The next dentist, if that new patient came to the next dentist's office and they had posterior open bite and there was no appliance, they wouldn't say, oh my God, how are you eating? How are you chewing? How are you functioning? You need ortho. They would say, is everything okay? But because they're part of their record and they see a change, this is upsetting. Laurie, you were going to speak. I'm sorry. Dad. We don't hear you. We don't hear you, kid. You're not muted.
Laurie, speak up. No, now you're muted, Laurie.
Now you're muted. You weren't muted before. We just didn't hear you.
No, it's interesting.
Not getting you. Is there a mic? Do you have a mic?
Let me make a comment while you're trying to get that.
Laurie, excuse me. Let me just give Laurie an instruction. Laurie, if you go to the wagon wheel on the upper right and you click on it, a little box opens up. Make sure that you're on computer audio, which I'm assuming you're on, right? And then after that, you have the right microphone picked. If maybe you have alternatives there. There you go. Now you're live.
Let me try this. Can you hear me now?
Yeah. No,
Yes.
Good.
Okay. Listen, one of the greatest fears that dentists has is when other professionals criticize them. And so that's one of the reasons why a lot of dentists don't do sleep and don't do pain. Now, with regards to AM aligners and this kind of thing, I really feel that you have to go back to Don's little gem that he gave us, one of the last speakeasies, when he was talking about phenotype. There are patients who are more vulnerable for bite changes than other patients. Don, Barry alluded to it, but also you can widen that a little bit from experience, and you can, when you do see bite changes in people who are more vulnerable than others, when you put down the risk before you even start appliance therapy, and you put it in your chart that they're a high risk and you explain it to them, that makes a big difference when you're using the concept of phenotype. So early on in the process, you need to protect yourself from the college and the lawyers. And so when you lay the groundwork, at least in my mind, when you lay the groundwork before you even start treatment, and then you follow it along in ways that you're monitoring these patients. And of course, if they don't come, you can't be held accountable if you put that in your chart that you have set up appropriate monitoring programs. This goes a long ways to firewalling you from some of the crap that goes on with lawyers and people's misperceptions. I hope I've made a contribution worthwhile.
Yeah. Thank you, Laurie.
Yeah, it's great. Thanks.
Well, I didn't mean to leave the message that I don't document, but I do perceive that the patient management part of is different than the litigious part of it. I know they're intertwined, but I try not to alarm the patient with the litigious part of it, not to protect myself, which is part of it, but to better manage the patient so I don't make them unmanageable, if that makes sense, because we can do that in healthcare. We can keep patients from moving forward. We can deceive them, which I'm not talking about doing here, but I just found less is more, so to speak, and to summarize that, I answer all the questions. I bring things up that need to be brought up. I certainly inform them if I see something, but I don't make a large issue out of it compared to the fact that years ago I might have been alarmed about it, and I just passed that right on to the patient. I don't do that now. So anyway, enough said there.
Yeah. One more comment about anterior midpoint. Sorry, not anterior midpoint. Sorry. AM aligners, spike jigs, AM warning aligners, whatever you want to call them. So Alan Loach, this was in about 4 years ago at a conference. He was straight out asked, so how do you feel about the use of these AM aligners? And he basically, his answer in front of the 400 people in the room was that he's hot and cold about them. He's concerned about their use on a daily basis, and root resorption and the implications for the teeth is you're putting force one way all night long, then you're jamming them the other way, in the morning, and this back and forth thing. I think over a long period, he feels as an orthodontist is concerning. Now, the AADSM basically says that we should be using AM aligners, but carefully, that more research has to be done as to their long-term safety, because there's not anything long-term published about their use. And so it really is Wild West with regards to what we know about AM aligners. I use them routinely. I follow up on their use, but I don't enforce their use. If the patient doesn't, then they don't, and I document them. Yeah.
What instructions, John, do you give to the patient when you give them their AM aligner?
Well, first of all, I tell them to wait about at least maybe 10, 15 minutes after they take their clients out before they do anything. Just let things relax as much as possible. And then gently go through the motions. What I do is I have them protrude the jaw, left, right, open big, and then close down as if you're closing backwards towards your ears. They understand that will lead to sort of a backward motion with their jaw, to bring their jaw back, as opposed to biting forward, right, type thing. And I say, do that once or twice, but don't strain things. Right? Don't do it so much that you're straining things. I always emphasize that. And then put in the AM aligner and slowly, pump into it until you feel that you're biting in all the way. And if you're biting in all the way, that means your jaw has gone back all the way, right? And do that as much as you need in order to get your jaw back as best you can. And if you can't get it back the whole way, wait a while, maybe try it again a little bit later, maybe at midday or whatever. Everybody's going to be different. But what I can't tell you how often, before I started stressing to people, make sure you don't overdo it, you don't strain to try and get your bite back. How often I'd be dealing with, oh, this is hurting now, the appliance is hurting my jaw, and after checking everything on the appliance and everything's fitting properly, I discovered, this doesn't happen anymore, but it used to happen before I learned this, I discovered that they're just hurting themselves every morning trying to get their jaw back. The moment they changed the protocol of what they were doing, and I would discover that by asking them, okay, so what are you doing in the morning? And they explained to me, so, geez, that's what's going on, right? So when they would change that up, and then all of a sudden, magically, the jaw's not hurting anymore,
I'm convinced that there's more jaw pain from inappropriate use of the AM aligner than from holding the jaw out at night, the mandible out at night. But let me ask you a question. So when a patient wakes up in the morning and the mandible is, and the teeth don't come together, the way they did when they went to sleep when they take the appliance out. Why is that? What is it that we're correcting with our AM aligner? Or in other words, what are we fighting? What if naturally the teeth are now, the mandible is now the trajectory is altered or something has changed, and now when they close naturally, they're closing without their back teeth touching. What happened? What happened overnight? What is it that we're fighting, that we're combating, in order to attempt to bring the teeth together? I mean,
Lateral pterygoid contraction.
Right? I mean, what?
Lateral
Sorry?
pterygoid contraction, theoretically.
One.
And fluid in the joint.
Well, okay, so that makes sense. But why? Why would holding the jaw forward with that? It's not. It's when you look at the lateral pterygoid. What's its main job? It's to bring it. It's involved in bringing the jaw forward. But we're nowhere near, the end of its range of motion. We're not. If we were to take an EMG level, the lateral pterygoid, and a sleep appliance just sitting there, what do you think it's going to be? So and why would it stay contracted? I don't get it. I understand that contraction would do it. I'm not convinced. Don, what do you think? I'm not convinced that we're seeing.
Any muscle across a joint, its job is to keep the joint surfaces in contact. So if you bring the mandible forward and there's translation, the lateral pterygoid contracts. It just does.
Right.
Now,
Right.
Is it fluid or is it the joint? Is it a muscle contraction? I don't know. But my hunch is for to be a permanent posterior open bite.
Yeah.
For a permanent posterior open bite would almost have to be a lateral pterygoid contraction.
Okay. I don't know. I mean, so that's one of the answers. The other answer is what? Increased altered fluid in the joint.
Right.
And then the third one is, we've lost muscle engrams. We've lost whatever it is that we normally have, and so that normal muscle function, that swallowing that we do 2 to 9 times an hour, is now different. Everything's changed. So whether we're dealing with muscle engrams, whether we're dealing that may involve pterygoid. So when I say pterygoid contraction, the tendency is to think of it as as a spasm of some sort of contractive mode. Well, clearly it's not that. So my point is.
Well, hold on. Before you go to your point, Dennis, I think wanted to add something to that.
Yeah,
Please.
if you Barry knows that I used to do a lot of ortho, and we used to do a lot of functional appliances. And back in the 80s and 90s, there was research coming out of U of T that showed that if you put a functional appliance in the monkeys, and this was done in monkeys, that between 9 and 12 months, you had new bone deposition in the glenoid fossa, as well as the head of the condyle, which caused a more permanent repositioning of the mandible forward. So you think that if you look at a sleep appliance and you're wearing it at night, 8 hours, 9 hours a night, over 9 to 12 months, that permanent change that you could get, depending on the age of the individual, because the condyle is a growth center, especially in kids. And you could get actual new bone deposition in the glenoid fossa and in the condyle, causing that posterior open bite. Because if you just sit there now, slide your bottom jaw forward, your teeth separate in the back. We know that. That's constant. But in the orthodontic literature, people used to say, well, functional appliances don't work. The reason that they don't work is because the dentist never left it in long enough to allow for that growth, development, and change to happen. So if you look at, and a tap appliance is a great appliance, and it is probably the epitome of a good functional appliance for orthodontics. So when I started putting my patients in their functional appliances and holding them there for 12 months, especially in a growing individual, those patients never relapsed. If I did it less than 9 months, they relapsed. So there, and finally, the literature from the orthodontic world showed that you had bone deposition in the fossa and on the condyle. That could be another reason for permanent change. And we don't know, if you believe some of the craniosacral literature, that these growth centers can actually be active in patients up until about the age of 60. It's a very interesting world.
But Dennis, wasn't that work with bonded Herbst though?
Yes, that work was done with a bonded appliance, and it was done in a shorter period of time. But they.
No, I don't think that's
Right, Don, that's exactly what I was thinking here is with that you're wearing it 24/7.
Yeah, but what happens is the caveat. Recently, they found that the amount of time that you need to have an appliance in a child is 8 to 9 hours a night, because during sleep, what other hormone do we know that is produced during sleep? Growth hormone. If the kids can wear that appliance 8 to 9 hours at night while they sleep and not during the day, you can still get that permanent development because you're activating the growth hormone. And what does a functional appliance do in kids? It opens the airway. So kids are now sleeping better, and you're changing that whole physiology. And that growth hormone connection with the functional appliances was about 2 years ago in the ortho literature, which was kind of fascinating, because it answered to me a question: why did some kids who only wore the appliance, I would tell them, wear it from the minute you finish your dinner until you wake up in the morning. So that could be 10, 12 hours for a lot of kids. They were actually doing better than the kids that I was telling to wear the appliance all day long. So it was kind of, I didn't know about growth hormone.
The other thing is, everything I've seen now, so when we've looked at, it's interesting, when we looked at patients who were in NTIs, or anterior points of appliances, and developed anterior bite, when we looked at those patients, we looked at them carefully, and what we did was we did corrected tomography, and we're trying to figure out what the hell's going on. And we were given that same information: is that we may be develop condylar changes and bony changes. And we did an in-depth analysis of all of our patients, and then we did an in-depth analysis in the research, and found that in fact we weren't getting condylar changes. Now, admittedly, this is totally different than a sleep appliance on an adult patient. But it would seem to me that it would be pretty easy to figure out, to look and see whether or not we've had condylar changes. And there's a lot. My point, and this is fascinating, and it may be valid, maybe actually, but my point was to suggest that no matter all the research that's been done, there are people that have the answers, that think they know the answers, and that we're not convinced. There is no definitive answer. I think that's a really strong possibility. I mean, I'm not questioning that, but we don't have the answers. What I do know is this. Is that that there's more damage done to joints attempting to force them back the way that exactly as John described it, and that there's lots of different ways to give AM aligner instructions. I think John's is an excellent one. We talk about pumping. We talk about relaxing and putting it in certainly 10 or 15 minutes afterwards. We certainly don't make the goal. I don't ever say I want your teeth to come back together. I never say I need your jaw. Your bite may feel slightly different, and sometimes, and that's okay. But this could help normalize it. I'm not over concerned. I make that very, very clear. What we did learn, and this is the truth, what we did learn is that in the absence of AM aligners, what we often found was that telling patients to keep chewing gum in the bathroom, to get into their shower in the morning, run the hot water on their face, and chew gum during their shower. Remember, they're probably not getting in the shower until 10 or 15 minutes until after they've woken up, and now they get in the shower. Now they chew gum, and then go on with your day. And you're, as far as I'm concerned, we're done. And we have found the same thing John has found: elimination of pain, no increase in occlusal changes. In fact, as I said over time, I think they're decreasing. I'm not sure why. Whether the appliances are getting better, I don't know the answer to that. But there's no question. But for the last 3 years of my practice of sleep, we were seeing far less. And now in our sleep program in New York, that I run, we're seeing far less occlusal changes. And I don't have an explanation for that. But the gum chewing has been a good answer for us. It's just something to consider. Great, good discussion.
I have a question, if I could ask it of you guys. So this is what I do, not necessarily what anyone else should do. I don't so much, I make AM aligners, but I don't so much tell the patient is to reposition their jaw. I tell them it's to help them detect if there might be a change and to let me know if there is. So I'm not having them clench into that. I'm using it as a reference point. I've not had a lot of discomfort with them using that because I don't ask them to forcefully try to reposition anything. And I've had less problems with symptoms, which are minimal anyway. And I've not had a lot of bite changes, knock on wood, but that's how I describe it to patients. Is that, in your minds, a good idea, or should we be telling them that we're trying to, from a teaching standpoint, that they should be using it, or they won't get their job repositioned?
I'm hypersensitive. I am wrong about this. So I'm going to tell you right now, what I'm about to tell you would be considered wrong by many people because I'm a little hypersensitive. We've had 3 too many cases of occlusal dysesthesia that led to serious consequences in our office that I am hypersensitive about patients. We've had patients that come to our office and their chief complaint is, Dr. Barry, you have to help me, my bite's not right. Or Dr. Barry, you have to help me, my bite's not comfortable. I've had everybody's trying to adjust my bite ever since I had that crown done, and they just can't get it right. I hear you're the best in the world. Get my bite right. So I'm a fanatic about occlusal dysesthesia out of perspective. I admit that 100%. So I am very sensitive when I hear somebody say, use the word bite to their patient. I'm opposed to the concept. And I'm not saying I'm the first to admit it, it's me. I don't like ever. I think that the T-scan is an extremely valuable instrument that is used wrong and improperly 98% of people who use it. If you use a T-scan and you show a patient the lines and say you're 60% bite on the left and bite on the right, just imagine what message that's sending to the patient, how important your bite be even, etc. And yet I think T-scans are valuable instrument when used properly. So I'm just very, very conscious, very, very aware. Just think about this, John, about using the word, I'm going to get your jaw back, or your jaw's been health. You know, I have no problem with oftentimes during the night, there's an alteration in how your jaw sits, and this improves that.
Yeah,
when you go to eat your breakfast and you find your things are a little different, your teeth don't, you just say, oh boy, this is different. That's normal. Don't be concerned about that. Yeah. So, am I right? No, I'm not saying I'm right. Don, what did you comment on that?
It depends on the person. It depends on the patient. those changes happen so rarely now. I don't really even pay attention to it that much.
I know. It's true. True. Great, John. Great. Anybody else?
I have a question about.
So has that patient ever
Paul
complained?
Alter is
Like,
here with a question, Barry. Our friend Paul Alter is here with a question.
Great.
Yeah.
First, happy birthday, Dennis.
Yeah.
Yeah, I came on when Barry made that comment about a Jewish man and his.
It was very short-sighted. It was a short-sighted comment.
Very short, from what I understand, anyway.
All right,
John,
I got a few things. The first thing was when you said that when you protrude the jaw, your airway is getting bigger, and that might actually make it more tend to collapse than if it was
I never said
not
that.
as wide. So are the and I know you're not like a big believer.
I'm gonna stop you. I never said that.
Yeah.
I never said that.
Could you repeat it?
Yeah. What I said was that when you look laterally on a plain film, when you move the jaw forward and you look simply at AP, the airway will appear wider. The suggestion by some is that therefore I have appropriately moved the mandible to decrease compliance. That fact that you see it wider has nothing to do with compliance. It may be less compliant, it may be, but the fact that you see it wider on an AP film, two-dimensional film, or even a three-dimensional film, has nothing to do with the likelihood, or no significant potential for the likelihood of whether or not the airway is going to collapse tonight.
When I'm looking at a CBC and I'm getting volumetric and area measurements, and I see an increase, are you saying that doesn't necessarily mean that the improvement in sleep is there?
Okay,
There's
so
never
Paul,
been a study to show correlation between CBCT findings and the airway during sleep. That's why they do sleep endoscopy to determine appropriateness of any sort of.
Okay, so let me jump in here.
If they're looking, for example, if they're looking for Inspire, if you're looking to see where the pinch point is, they can't look at a plain film. There are certain pinch points that respond well to Inspire, to a stimulation of the glossopharyngeal, and so you can't look at a plain film to determine that pinch point. You can't look at trigonometry to determine that pinch point.
Could I make a comment?
Sure. Who is it?
Yeah, David Zimmerman from Auckland, New Zealand.
Hey,
I saw.
David.
I
Sure. How are you? My goodness.
I walked out of a presentation you were doing, a week-long presentation, because I didn't think I needed to know anything about sleep. I've since learned a lot.
I remember.
I've done a. I was prompted to get involved in this by a whole lot of things, but same as a march of time. But a Chicago orthopedic surgeon had great success in lower back pain patients when he gave them a box of Breathe Right nasal strips. Now that shows there's a big, strong correlation between all of this. But I've shown in a paper I wrote called Airway versus Spine, Who Wins the Race, which is a Ceph and pharyngometry related paper. And what it shows quite clearly is that in sleep, the whole architecture changes radically. And so what you're seeing in the these images, CTs and MRIs and so on and so forth, and even plain films, is the awake and adjusted posture while the person is awake. Now, that's a completely different situation than what happens at night. And it's taken me a long time to cotton on to this, but I've found that I tracked the rise of major health issues in the 1800s. And that coincided with the increase in production of tobacco, alcohol, and sugar. And then I couldn't figure out what that was all about, but it turns out from a French team, they showed that exposing embryos to these factors in the first week of implantation kicks out the neural crest cells and swaps them for Hox genes, which results in a smaller nasomaxilla. And there's the key to the whole problem. So what actually is happening is that, and if you look at the Oslo study where they looked at kids' skulls from 400 years ago and currently, the current kids of 12 years of age needed almost double the amount of orthodontics, which indicates that they've got smaller jaws, but it's only the maxilla that's really affected. So you follow that through and you find out as the mandible is drawn backwards, there is more intermittent hypoxia, and that's the key to generating all systemic inflammation. So these things like diabetes, COPD, atrial fibrillation, and the whole lot are all interrelated. And that's the pattern that I've found. I'm almost finished doing a review of all of this, and I'll hopefully get it published this year. But it's a very unpopular thing down under, I can tell you. Our dearly beloved dental board took my license off me because they think this is quackery. And even though the case they did, the lady stood up and said, did I help her? He said, yeah, you saved my life. But they still can't get it. They attributed it not to airway issues, not to TMJ issues, but to an infection, which was non-existent. But the point of this is that people just don't get most of this stuff. But you guys are right on the button. You're right on the crest of it. But I would encourage you to have a look. I've written, hopefully, to John, and because I applaud what he's doing. And I think, Barry, I've still got your big folder and refer to it a hell of a lot. And things haven't changed. They're quite remarkable. We just keep on kicking the stones over and finding new lumps underneath them. But all of these things have puzzled me for a long time. And, so I would put that in. And the second part of that equation is not only do you get intermittent hypoxia, but you also bring the the mandible rather, back, and you get an inherent increase in the amount of compression in the bilaminar zone. And a Professor Otsuka in Japan did an MRI study and showed within 10 seconds of wearing a splint with a ramp on the front to compress that tissue, the MRI showed an involvement of all the areas of the brain that were emotive and pain receptive. So some of these kids actually abandoned the thing within 10 seconds. They felt overwhelmed and suicidal, which shows the incredible power of the TM joint. People have no idea about it. Brendan Stack has done some very, very good videos of it. They're actually worth having a watch. But I put that in as sort of an overrider, not to say that, I think that your comment about the chewing gum is bang on, and I think it works because you're doing two things. First of all, you are probably doing your own cranial osteopathy because the joints remain patent. And the second part is that you're altering the tone in the submandibular and the hyoid groups. And they really will maintain that airway. And I've got plenty of x-rays that show the people with these issues and crowded teeth, which says short, small maxilla, and they're not nose breathers because they can't breathe through their nose, so they're mouth breathers. And the second part of that is it just goes on.
David, I'm going to stop you for a second. It's really interesting, and thank you so much for coming on. I'd love to hear more. I explained to John, I've got another meeting at 5 o'clock, and I don't want to see you, but I really need to go. They're hammering at me here. So thank you all. I enjoyed it, John, and David, good to see you.
Thank you. Lovely to see you.
Good to see you, and John, and Jack, and Hillard, and everybody.
And thank you for the push you gave me to get started in this.
It was a real good push. I left my course. I'll see you later.
Thanks, Barry. We'll talk to you later. So, guys, listen, we don't have to rush off. David was in the middle of a thought. We'll let him finish, and then we want to really give Paul Alter's question a good answer before if he's still on here. But
I have
still here.
So, David, did you want to finish your thought?
Essentially, yes. If you have a look back at your patients, especially the young children, have a look at how many have behavioural problems. That's one. That's a good clue. And I'm actually trying to get some collaboration on this one. Is going bedwetting or getting up and going to the loo at night a valid yardstick of having sleep apnea? And I think it probably is. And we touched on that just earlier in saying, what are the hormones? And Barry said, what are the hormones generated during sleep? And one of them that's altered is vasopressin, and the other one is atrial natriuretic peptide, which is a one that's generated within the atrium as heart blood comes back into the heart. Now, if you've got an apnea and you've got a lower pressure in the thorax, the atrium will be expanded or overexpanded. So you not only get the atrial peptide produced, you also get valve problems, atrial fibrillation, and so on. All of this stuff goes on. And if you see these correlations and you start to look for them, you'll find that most of your adult patients, especially over the 50s, will have the same pattern of medication that says the same underlying problems. And that's what pushed me along this whole path. But it's been an interesting journey. But really, you start to see these things are far bigger than crowded teeth and a small arch.
You know, David, just when I started getting into sleep, we had a ear, nose, and throat combination dentist. He had both degrees. So he made the appliance, a Somnodent, for a patient. He gave the patient the key to get rid of the snoring. So the patient who happened to have rheumatoid arthritis, so I guess the ligaments of the TMJ region were more lax. So as he kept moving it forward to get rid of his snoring, he dislocated on one side. The doctor, he didn't know what to do, and I certainly didn't, because I was just in the middle of my courses. So I talked to a physio, and he was telling me about, you know, here's what you got to do, like to try and move the mandible to get over and around your dislocation. And so I was very gently just pushing, like posteriorly rather. And the next thing I knew, the guy's in the hospital, his blood pressure went through the roof. And I thought, I'll bet you I did that by pushing that condyle posteriorly against those retrodiscal tissues. Do you think so?
Yes, I do. There's a group called OSA University that I've listened to from down under, and they showed they can titrate a mandibular position in certain patients that will limit the amount of heart rate variability. In other words, if they've got one of these restrictions on their heart rate variability, if they run upstairs, they can collapse. The heart can't cope, it can't change its rate. So I suspect that you've noted this, and it's that just shows you that you've got your eyes open and you're just watching. I don't know the answer to it, but I certainly believe that it does happen. I have no doubt. Atrial fibrillation is a good example.
Okay, let's close down the answer that Paul first positioned here, because he actually brought this up last week, Paul, and we talked about it, and I thought that we had addressed it, but obviously it's not addressed in your mind. Before, I think Dennis Marangos was waving by. I just wanted to make sure he's not on here, that he wanted to talk. Okay, I don't see him here, so he must have been waving by. Okay, so you asked about the volumetric information you're getting on the CBCT and its value. Okay, and that's how it led to all this other discussion. So as was mentioned last week and what Don repeated this week, let me just explain. In the literature, it clearly shows that a larger airway is related to a better HST outcome than a smaller airway. There's evidence of that. So yes, larger is better. The problem is that it doesn't guarantee that the apnea is going to be resolved, because what we have is larger is better, smaller is not more likely to be not acceptable, right? As far as HST or polysomnogram findings, right? However, there's a tremendous overlap between those two groups. So you have people that have a small airway, right, that don't have apnea. That with a PSG or an HST, they're fine, they're normal. Then you've got people that have a really wide open airway that and still have a meaningful level of apnea. I don't know where that noise is coming from. Maybe it's from Rich. Rich, I'm going to mute you. Good. So that's the problem. The problem is there's physiological reasons for the apnea. So just looking at the airway volume alone is not going to give you an answer. Yeah, shooting for a larger airway is good. But the thing is that most of the time when we advance the jaw, the airway is going to get larger. I'll tell you, there was a small study done by a guy named Dan Loeb. This was perhaps, I don't know, Don might remember, this was the contentious citation that you couldn't find.
Footnote 44.
There you go. And it was done by Dan Loeb, and what he looked at is the use of pharyngometry. And what he looked at is he said, look, it doesn't really predict success, but it's pretty good at predicting failure. So when it didn't demonstrate a good increase in size, right? It had a reasonable predictive value of it not working, whatever you've done, right? So it had a negative predictive value, but it didn't have a very good positive predictive value. So, okay, made the airway bigger, but, you know, 60% of the time, if I'm recalling correctly, you know, it was a success. Well, 60% of the time, it's a success no matter what you do, with your eyes closed, blindfold on, and not even paying attention. So it really brought no value at all having that information. Okay, so the point is that airway volumetric information alone does not bring any value, because you don't know whether this is somebody that's got a big increase, that's still going to have apnea because of physiological reasons you're not seeing here, or somebody that shows to have still a small airway, but in the end, they're not going to have apnea as measured with an HST or a PSG, right? Even though they have a small airway because of the crossover in those two groups. So you can say, I'm going to use it for patient education and this and that. This is what Barry was referring to earlier as really this is fraudulent. You're just showing an image of something, representing it not at all the way the science would represent it, and it's just bullshit. And I agree with them on that. I don't believe that this is good to be showing the patient and show, look at how much bigger your airway here is, this is what the appliance is doing, and that can be interpreted by the patient. Well, I mean, that's great, it's going to work. And now you could be using it as a closing tool, but it's really fraudulent to be doing that because that information does not assure us that. Okay. Now we talked about this last week, and we just talked about it again today. I just want to make sure, Paul, I know that you're resistant because you believe in all this stuff, and that's fine. Just understand that what I'm telling you is that's what the literature tells us. This is what the literature tells us, right? Yeah. There's nothing published that shows that there's two groups. Wow, this smaller is bad, larger is good. Larger doesn't guarantee it's going to work. Smaller doesn't guarantee they're going to have apnea. That's the bottom line.
Can I ask another question?
Sure. It's 5:07. I don't know how long people want to stay on, but yeah, let's take one more question. Yeah.
All right. Bite changes. Sorry, no. The occlusal dysesthesia. I guess I can refer more to the decades of doing occlusal adjustments before I knew more about them from the TMJ course. But I found that the people who were really hypersensitive, including myself actually, about the slightest little bit of enamel that you might touch, and I found it in a couple of TMJ patients and in some of the bite adjustment patients I had, really have a neck problem because the center of rotation is the dens. So when you start changing the tooth surface, you're actually changing where that condyle is in the housing. And depending on how the muscles tend to react, if you have a neck problem, they're going to be hypersensitive because, well, your teeth might be able, they're in a PDL, they might be able to handle, more jostling. Your neck certainly can't, especially if you've had, an alordotic spine or you've been hit by a car, that kind of thing. And I'm wondering if it's not a psychiatric problem, that they've got a neck problem or some kind of a spinal problem, and the teeth just are a great place to source it out.
Don, I'm going to make a comment, but then I'm going to let you respond to this because you're actually more attuned to that whole joint thing, right? Paul, I'm not going to say it's a psychiatric problem, but I'm going to put out there that it's an approach to the whole thing problem, right? So you get in one, and the reason that you have to be careful about making somebody too acutely aware of their bite is that if they become too acutely aware of their bite, all of a sudden their bite becomes an issue. All of a sudden they can't concentrate and focus on anything else, and you created that problem. So is that a psychiatric problem, or is it that's just you're teaching them a certain way that's not a good way? And I think the clinician can fall into that trap too, where they get so obsessed with all this stuff that then the patient sees that, well, they're still working it, they're trying to find a sweet spot with the bite, and it's just a vicious cycle downwards, and you're trying different things. So that's just my opinion. For somebody that does not practice orofacial pain and TMD, I change bites all the time with oral appliances. I have for years. And I don't have patients coming in falling apart at the seams and having problems, or even stop wearing their appliance, because of the changes that have taken place. So when I hear about these things, it's really foreign to me, even considering that I've been doing this for 25 plus years and placed thousands of appliances and not had to deal with the ramifications of bite changes, creating the types of issues that are supposedly supposed to happen if the cusps don't align just right, right? So it's foreign to me. So Don, I'm going to let you speak more from a literature point of view.
You can't separate neck function away from mandibular function. Even while awake, the first muscle to contract before you open your mouth are the deep cervical muscles. I can post the reference here in a minute for you. So you can't separate out neck function. And before, when you spoke about decompressing the retrodiscal tissues to see the changes you got, you're assuming that, but you're also creating a neck change. So to say that all that's coming from retrodiscal tissue is frankly preposterous. So and I'm going to put the reference up here. It comes out of Finland.
You're going to post it in the chat, Don, or do you want me to have your screen? No,
I'll post it in the chat.
Okay.
Could I make a quick comment?
Sure.
Patient came in to see us, very rotten teeth, and I wondered what it was. So I asked, and she said, "Well, I can't hold my toothbrush, not since I've had my shoulder surgery." So I found out about that, and it tracked it back to basically a whiplash injury, where she had a 140-kilo woman land on her in a bus where it stopped suddenly. And she'd had 2 neck fusions, multiple physios and what have you, and then because it worked and stopped the pain, they put an injection local into the levator scapulae muscle. So they cut it off, dropped her shoulder, stretched her brachial plexus, gave her a carpal tunnel. And that made me pretty upset. So what I did was I used a phonetic jaw position, checked that with pharyngometry, found out that that was ideal, and put her in that. Now, she'd been living on painkillers for 3 years, and she came in the following week and looked pretty grumpy, and she said, "I don't understand this. But since I've had those two daytime and nighttime plates in, I've had no pain. Now, what that was about was we stopped the compression of the retrodiscal tissues, which does happen, and it's real. And the second part is we arranged her airway so that she didn't have to adjust her neck so adversely. And as soon as that happened, which is reflexive, as soon as that happened, the pain generator was switched off.
Interesting.
And I've done quite a number of those.
Thoughts, Don?
There's some really interesting work out of Japan done on what they call body sway. If you take a patient, have them close on their back teeth and stand on a plate in a gyroscope that measures how they move, and if you then put something between their teeth to separate the jaw, you'll reduce body sway. So mandibular position and its feedback through the neck determines posture throughout the entire body. There's cerebellar feedback mechanisms. It's a really complex system. So is it just the retrodiscal tissue? Well, I think you'll get pain there. I don't think you're getting a ton of proprioceptive input out of the retrodiscal tissue.
No. But we've done too many cases not to. In fact, Shumway Cook actually got this from up in Seattle. She did this research in the 1980s, and you can see somebody who's got TMJ, when they're walking into your clinic, you'll see the ipsilateral arm does not swing. But there's also an Italian group called D'Italio, and they've shown that in young rats, they built the molars up on one side and gave them all scoliosis. 2 weeks later, they built the other side up with just plain composite, bonded composite, and the scoliosis about 80% resolved. So I think that the base of the skull plane and the plane through the airway and the volume of the airway is the most critical factor. It's taken me a long time to be confident to say that, and we've seen many people who've done it. We've got loads of such cases that people locally just don't credit it. I think it's witchcraft, but it's hard fact. You can actually prove it and show it. It's but I agree with you.
And publish it, David. Then you got to publish it. Otherwise, it's just your opinion.
I know. And I have Acta Neurologica has got the one that shows the embryological development and how that changes, and you finish up with a smaller nose and maxilla, which is one of the big key factors. But it's it's interesting, and because it forces you to look a bit broader and see why were these people who come in have got all the same health problems. And you see the migraines. We had a lady who'd had a migraine. She was 50 something. She'd had a migraine pretty much every day for her life since mid-teens. And again, we made jaw position correct for the airway and for the TMJ and the facial and chewing muscles. So they were symmetrical and so on and so forth. And quite often they're not. Got closer to that. What's it? Robert Shimbasi, his study on EMG showed that CEJ to CEJ in the anteriors should be about 20 millimeters. And variations from that will increase the amount of EMG activity in the subhyoid and the chewing muscles. So those things have got to be respected, but there's no one single factor. You can see this in somebody who's got a belted pelvis. They've twisted their pelvis. I can show you a good video from a guy called David Shirazi, who's in LA, and he did one on people with Parkinson's disease. And he shifted the jaw forward, and the chiropractor held the pelvis together. And the simulation from that was enough to stop the untenable shaking. This woman was completely unstable. She couldn't stand up. And as soon as they addressed those two issues, she was posturally stable. And idiopathic scoliosis is one of the topics we're looking at. We're actually about to do a study looking at EMG in the lower back muscles and comparing that to the size of the throat using pharyngometry. And I think there'll be a correlation. I don't know, but I think there will be a correlation, which has implications for people with lower back pain and repeated back surgery.
David, can I ask you a question? Can I ask you a question? You're using pharyngometry to measure the upper airway.
Yes.
Is it at baseline, or is it that, with jaw repositioning?
We do 4 positions normally. You can do as many as you want, but we normally do 4 positions. The first one is normal passive breathing. Then the second one is normal passive breathing jaw position, but you slowly, over 6 seconds, exhaled all the air and force a pharyngeal collapse. And then you can measure that. And then you shift the jaw forward to whatever position you want, because that's the typical MRA position. And the last one is normal bite with a 3 to 4 millimeter gap between the back teeth. And you compare these things, and we see kids who have gone from a...
David, before you continue, you're about to spend a lot of time doing this, right?
Yes,
okay.
Probably 20 years.
Right, so before you spend 2 years doing this, I would suggest you look in the literature to see if you can find that those measurements using the pharyngometer are validated. The only thing you'll find is that they're validated at baseline. But once you start repositioning the jaw, right, there is nothing in the literature that validates the pharyngometry reading. And in fact, I really truly believe it's not valid. And I've got something that's going to be published that demonstrates why. So I'm just saying, before you go into like the repositioning of the jaw, the problem is all bets are off, because that data is tainted. And I'll just tell you why in a nutshell here. I know the group has heard it before. For pharyngometry measurements to be valid, that nasopharyngeal seal needs to be intact, right? Right? If you follow the instructions in the manual, the soft palate has to be up against the posterior wall of the pharynx, so that nasopharyngeal seal is intact. You cannot have leakage. Sound wave has to travel down and travel back. And you could take your FRC measurement, your RV measurement, whatever you want to do, and it's all validated, and it's compared to MRI and CAT scans with a very small variance, it's valid. Okay. Now, the moment you know the answer to this question I'm going to ask you, when you move the jaw forward, what's happening to that soft palate? What do we know about mandibular advancement? It makes the airway bigger, not only behind the tongue, not only down in the hypopharynx, but also behind the soft palate. So that soft palate pulls off the posterior wall of the airway. So once you reposition that jaw, or once you put something between the teeth to open up the vertical, what's happening is that soft palate, to some degree, is going to move off of the posterior wall of the airway. So what's going to happen is, distal to that point, the sound waves are going to travel downwards, and they're going to travel up into the sinus and come back. And it's a dumb algorithm. All it's doing is measuring sound waves that are bouncing back. So what it does is it adds the volume in the nasal passages to the volume in the pharynx and the hypopharynx, oropharynx together, distal to. So when you look at that line you see, the pharyngogram you see, distal to the leak, it looks like the airway got bigger. We moved the jaw forward, the airway got bigger. But what you're looking at is tainted data. You're looking at data that represents the volume distal to that point, going down the airway and going up into the sinuses. In rhinometry, which is exactly the same technology, they have documented this in their research, that when you have a leak from one side to the other, the nose, right, distal to that, all the data's invalidated, because what it does is it adds the two volumes together, distal to that leak. So up until that leak, the data is valid. But beyond that leak, it goes all wacky, and it's way too large. And it's way too large because it's just added the two volumes together. So in fact, pharyngometry is being used to demonstrate how advancing the jaw is going to improve the airway size. But in fact, what you're looking at is fictitious. It's not representative of the jaw. and I'm sorry, of the airway. It's tainted data. Now, the reason I'm telling you this now is you're about to embark on a 2.5-year project. Do that due diligence. Find validation of the pharyngometer in an altered jaw position. And if you find it, please send it to me, because I know none exists, and I'd like to be proven wrong on this.
No, I take your point, really do. I don't trust any data, because it doesn't take long, and most of the things that you've held as sacred get tipped upside down within a few years.
Well, the thing is on that is pharyngometry. I first saw the pharyngometer in 1998. It was demonstrated at New Orleans. At that time, it was Sleep Disorders Dental Society at one of the little side shows, and Wayne Hallstrom, the developer of the silencer, was showing it to us. And I thought, wow, this is really cool. I'd like to get involved in that. About 18 months later, I had one, and I got involved in doing some research with it. That's why I had this experience back then. Back then, I was trying very hard to demonstrate clinical utility, because much better than just getting subjective feedback. HSTs weren't available to us; they were too cost prohibitive at that time, right? So this was the answer, but I was never able to actually demonstrate clinical utility, and I believe that this is the reason, what I just explained to you. And we actually did a study with an in vitro study with a cast of human airway, creating a leak, showing that the cast of the human airway gets bigger distal to the leak, and it's proportionate to the size of the leak. You know what I mean? So, that doesn't just happen, but it's not being done in a human, it's being done in an in vitro setting. And that's the study that's going to get published. But I just, want to caution you on that before you go down this road, because I know firsthand how much work it is to do these types of projects. And if one part of it is flawed because you're hanging your head on something that's not validated, and it's just giving you erroneous information, then even though the rest of the work might be good, that part sort of invalidates all the findings.
Yes.
Right? That would be a shame. That would be a shame, because that part, because you're hanging your head on that volume data, which others will look at it and say, what are you talking about? So that means everything else goes out the baby's going out with the bathwater. So that's why I'm cautioning you on that.
Yeah. I've been struggling to find, other than the fact that it's been convenient and gives reasonable figures.
Easy to use, inexpensive. I get it.
Good. I'll get you to send me that.
I wonder if.
Yes. Who was that? Rich?
Sorry. At some point, I'm a new member of this group and would love to give some input, but I don't want to interrupt all of you.
Well, yeah, listen, Rich, you know what? It's 5:26. We've been on here since 3, but since you're a new member, I would like you to say something and introduce yourself, and then we're going to call it a day for this week, because it's been like 2.5 hours, and we'll be back on here on Wednesday next week at 3. But please, Rich, introduce yourself and share what your thoughts were.
Okay, I will. Rich Cohen, I'm past president of the American Academy of Orofacial Pain and the American Board of Orofacial Pain. Teach at UCLA and at several institutions. Happen to be, just if you're interested, will be publishing in Cranio a study of airway measured on CBCT as just being a screening similar to stop bang. So if you ever run across that. But I just wanted to reinforce the idea that there's definitely a relationship between the neck and the jaw. And Roccabato is doing some research on that, but there's no evidence-based research that we can find. But I would like to support the idea that has been presented here, that when we do trigger point injections of the neck muscles, usually masseter and temporalis pain goes away. And there's, a lot of information to show clinically that there's a big relationship between the neck and the jaw. And I'm currently working on a research project with American Academy of Maxillofacial Radiology to show that it's important to include the neck in a series for orofacial pain because of that relationship, and we've got literature to support it. So that's basically my introduction to say I'd love to tune in next Wednesday to hear more of what you all have to say.
Perfect. Well, welcome, Rich. Thank you very much for joining us. And, folks, listen, 2.5 hours, talk about dental sleep medicine nerds. I mean, like, who would do that? I know how I got through it. I had 2 of these. I don't see any of you drinking, so I don't know how you've managed to do it. Anyway, thank you so much for joining us. And
thanks for doing this.
Yeah.
Thanks for doing this. This is like
my
heaven.
pleasure. Yeah,
It's really
it's a
good.
lot of fun. I'm a nerd. I love this stuff. So listen, be well. See you next week. We'll be back here. Oh, listen, before I go, I just want to announce tomorrow at 1 o'clock Eastern Standard Time, we have a new device. Anshul Sama is an ENT surgeon in the UK, and he's going to be talking about the snoozle. It's brand new to Canada as of the last few weeks. It's going to have FDA clearance in the next few months, and then it'll be in the States. It'll be available to all of you in the States. And what it is basically, it's like a tensine, not a tensine, but a neuromuscular stimulation device for the tongue to help stimulate a muscle, modification and becoming more fit. And he's got literature he's going to share with us on its usefulness for treating snoring and mild sleep apnea. He has an ongoing study right now with, I think, about 100 patients for moderate to severe sleep apnea. And what I'm excited about, I think I've mentioned this before, is not so much the mild sleep apnea or snoring, but as adjunctive therapy for those patients that we help with an oral appliance, but we still have a meaningful amount of residual apnea left. And we'd really like to do something to get rid of that. And perhaps it could play a role in that arena. So he's got a webinar, one of our bi-corona webinars. You'll find it on stdacademy.com, the registration link. And that's tomorrow afternoon at 1 o'clock. So I just wanted to share. We got others the coming weeks, but I'll just tell you about that one right now. So thank you very much, and hope to see you next Wednesday. Okay, cheers, everyone.
Thank you.